week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
Hi everyone, my name is Jessica Ellenburg and I am the second year emergency medicine pharmacy resident from Cleveland Clinic Akron General. And today we're going to be talking about RSI, to ketamine or not to ketamine. Just some objectives before we get started. I'd like you all to be able to compare Etomidate and ketamine for induction, review the previous literature that has evaluated these agents for use in RSI, as well as evaluate today's RCT, comparing the two specifically used for RSI in patients with sepsis.
Okay, so just for some brief background, Etomidate is a non-barbiturate general anesthetic. It increases the affinity of your GABA receptors, which causes that increase in CNS depression and an anesthetic effect. It has a 6 to 8 hour inhibition of adrenal steroid production following a singular dose. And some literature even suggests that could be upwards of 48 hours. It's dosed as 0.2 to 0.1 mg per kg over about 30 to 60 seconds, pretty quick onset, very short half-life, only about 5 minutes. Side effects to be aware of outside of that adrenal steroid inhibition could exacerbate some underlying myocardial dysfunction, although that's largely been debunked, and Etomidate tends to be one of our most hemodynamically neutral agents, so generally a safe option in these patients. Adverse effects outside of that include pain at the injection site, really due to that propylene glycol content, some nausea, vomiting upon emergence out of the anesthetic state, and then potentially some transient skeletal movements as well. Ketamine, on the other hand, is an NMDA receptor antagonist. It's ultimately going to cause an increase in your excitatory neurotransmitter glutamate, which can cause that dissociative trance-like state of sedation. It's given anywhere from 1 to 2 mg per kg, IV push over about a minute. Again, quick onset, a little bit longer of a half-life, longer duration specifically for that sedative anesthetic effect, about 5 to 10 minutes. That dissociative state's going to last a little bit longer. Of course, this is contraindicated per package insert for anyone with increased intracranial pressure or increased intraocular pressure, but that literature really comes from some studies that were done back in the 70s that found patients with non-traumatic intracranial lesions and therefore pre-existing pressure in their brain or in their intracranial pressure had increased mortality potentially with ketamine use, and that's been debunked for the most part. So also contraindicated in patients that have pre-existing psychiatric conditions because of the risk of the emergence phenomenon, and potentially contraindicated, or something to consider, I suppose, would be the laryngospasms that could occur largely in our pediatric patients, but there are providers that will deter using ketamine for RSI because of that risk. So diving into one of the first studies to kind of mention this, the Ketased trial back in 2009. This was a randomized control trial, excluded all of our high-risk patients that were cardiac arrest prior to RSI, and then those that left the ICU alive within 30 days. So really narrowing down on the patients that survived past that 30-day mark. Their primary outcome was maximum SOFA score during that 3-day period, and they found a slightly higher but not significantly higher SOFA score in the Etomidate group. Mortality-wise, that didn't translate to much of anything, and mortality was similar between the two groups. They also did consider adrenal insufficiency and defined it by utilizing adrenocorticotropin testing or a baseline cortisol test, and did find that was higher in the Etomidate group with an odds ratio of 6.7. So ultimately, ketamine could be a valuable alternative compared to Etomidate and could be considered in sepsis. So Albert came along in 2011, and this was a systematic review that conducted or included 21 articles in total, 4 randomized control trials, comparing really just looking at Etomidate compared to a number of different agents, including things like fentanyl, midazolam, and additionally ketamine. It was much larger with about 3,500 patients. Their primary outcome was that risk for mortality in the critical patient population, which they found a higher risk in patients that had received Etomidate. And they also evaluated adrenal insufficiency in those patients too, where Overall, in the entire patient population, they had a risk ratio of 1.64, with higher risk in the patients that received etomidate. And the sepsis patient population, that risk narrowed down a little bit to only 1.22. So there's an increased rate of adrenal insufficiency and mortality in patients who do receive etomidate, according to this trial. So kind of shifting away from the adrenal insufficiency concerns of etomidate and looking more closely at the potentially related hypotension, Van Berkel in 2017 conducted a trial specifically looking at clinical hypotension, which is defined there in the results section for you. They hypothesized that patients that received etomidate would have increased incidence of clinical hypotension. And overall, their primary outcome, that clinical hypotension, was not statistically significantly different between the two groups. They did do propensity matching to make the two groups more similar. And at that point, they did find a significant difference with more patients in the etomidate group, 73% of them experiencing clinical hypotension versus only 51% of the patients in the ketamine group, with that odds ratio of 0.39. The NEAR study in 2020 was also evaluating hypotension incidence. They had a bit of, stricter inclusion criteria with only patients who were normotensive prior to intubation. It was a much larger patient pool, but they were looking at that patient population with a systolic on presentation of 100 to 139, essentially. Upwards of 7,000 patients, their primary outcome being that peri-intubation hypotension, in which they did find a significant difference, but in favor of ketamine having more hypotension than etomidate did. And then they looked at treatment, and that did translate to a higher need for treatment of hypotension in the ketamine group, with a confidence interval that did not cross 1. So ultimately, clinicians should not necessarily prioritize ketamine over etomidate based on that clinical or based on that concern for hemodynamic compromise. So the EVK trial in 2022, this was prospective, randomized here in the US. They excluded all of those patients that were high risk, as well as those who were receiving intubation without sedation. The doses that they utilized are much more similar to what we see here. So 0.2 to 0.3 versus 1 to 2. And they used an intention to treat analysis. Notably, one of the flaws in this trial is that the airway team could screen out patients or choose to change meds. And because of that intention to treat analysis, they weren't able to actually exclude those patients. Overall, they had about 800 of them. Their primary outcome was 7-day survival, and they did find a significant difference in favor of ketamine for that mortality benefit. Their secondary outcomes, longer-term survival, vasopressor use, adrenal insufficiency, there were no significant differences between the two groups. And so based on kind of that brief literature review there's been a lot of conflicting evidence on whether etomidate or ketamine have effects on hypotension and vasopressor use, as well as any impact that they might have on mortality. So as a result, the question kind of still remains, which agent should we preference, particularly in that sepsis patient population who may already be hypotensive or be at risk of quickly developing hypotension? So that brings us to our trial today. So this is the question that they tried to answer: clinical outcomes after a single induction dose of etomidate versus ketamine, an ED, intubation, and RSI. So their primary aim to compare survival and peri-intubation adverse events after a single dose of either one of these agents. And diving into our methods here, this was a single center randomized, single blinded control trial conducted in Thailand. And it ran about a little over a year and a half from 2019 to 2020. The authors included any patient that presented to the ED with suspected sepsis, and they defined that by the sepsis 3 and SOFA criteria. And those patients had to be requiring induction for rapid sequence intubation. Patients with arrest prior to intubation, DNR orders, known or suspected adrenal insufficiency, severe hypertension, or suspected or evidenced increased intracranial pressure were all notably excluded. They were randomized to receive a single dose of the induction agent, either etomidate 0.2 to 0.3 mg per kg or ketamine 1 to 2 mg per kg. The provider that prepared the study drug was not involved in any way in the actual intubation process. And then a neuromuscular blocking agent, succinylcholine, in this study at 1.5 mg per kg was given immediately after induction, depending on the clinical state and any contraindications that the patient might have had. And then they used both direct or video laryngoscopy for intubation, followed by capnography for confirmation. Outside of the induction agents, I'd like to point out that all patients received the same standard therapy for treatment of sepsis based upon those 2017 Surviving Sepsis Campaign guidelines. The primary outcome was 28-day survival. Secondary outcomes included 24-hour and 7-day survival. Early hemodynamic parameters after RSI, the amount of fluid that they received within the first 3 hours after intubation, and then any peri-intubation adverse events, including arrest, failed intubation, post-intubation hypotension, and 24-hour vasopressor use. The authors they noted that they did perform a pilot study to determine their anticipated mortality rate. They calculated that 260 patients would be needed for 80% power to detect a 10% absolute risk difference with a p-value of 0.05. They did perform an intention to treat analysis for all of the survival outcomes, 24 hours all the way up to 28 days, and then calculated risk differences for all of their percentage results. So getting into the actual results, overall, they had 272 patients that they identified, 12 of which were excluded for hypertension on arrival. So all 260 of them received their assigned intervention and none of them were lost to follow-up. The average age of the patient population was around 71 to 72 years old. Most of them had a suspected respiratory source of infection, followed by intra-abdominal sources of infection. Some of the baseline characteristics that I would really specifically like to point out include the Glasgow Coma scores prior to intubation. A majority of the Etomidate group had GCSs of 9 to 13, while a majority of the Ketamine group had GCSs of 14 to 15. Q-SOFA scores between the two were similar. Initial serum lactate were also similar, maybe slightly higher in the Etomidate group. Fluid prior to randomization was 1.2 liters in the Ketamine group versus 1 in the Etomidate group. And around 70% overall of their population received succinylcholine prior to RSI. Notably, the authors did not give p-values for any of these baseline characteristics, but they did state that there were no statistically significant differences between them. The primary outcome of 28-day survival was not significantly different between the two groups, but 80% of the Etomidate group did survive to 28 days compared to only 73% of the Ketamine group. 24-hour survival, on the other hand, appeared to actually favor the Ketamine group with a survival rate of around 96% versus 91% in the Etomidate group. But again, none of these differences were statistically significant. Other secondary outcomes to note include systolic blood pressure during intubation, with patients in the Ketamine group having a trend towards higher systolic pressures. Oxygen saturation during intubation appeared to be similar between the two groups, but somehow yielded a statistically significant p-value. Cardiac arrest, failed intubation, post-intubation hypotension were all similar between the two. And then fluid volume following intubation was also similar between the two groups with a total of 1 additional liter. So your median in your Etomidate group being 2 liters and in the Ketamine group being 2.2 liters when you're accounting for the fluid prior to randomization. Despite the similar systolic pressures, fluid administration, and incidence of hypotension, vasopressor use within 24 hours was significantly higher in the Etomidate group at almost 43% versus about 18% in the Ketamine group. And then the authors did calculate a 26.2% risk difference in favor of ketamine. Additionally, corticosteroid use was higher in the Etomidate group at about 14% versus 5% in the Ketamine group, and that was also statistically significant. Ultimately, they concluded that there was no difference in the early or 28-day survival rates between the two agents, but Etomidate was associated with higher rates of early vasopressor use after intubation. And so my interpretation and some discussion on some of the limitations and the strengths here. So they did utilize very broad inclusion and exclusion criteria, I should say, including patients with suspected sepsis all the way up to patients that are presenting with septic shock. They set dosing ranges that are much more representative of the doses we will likely use here in the US, especially compared to some of the previous literature that has evaluated this or compared the two. By focusing on survival rates, that primary outcome that they have was really pretty patient-centered, especially compared to some less patient-centered outcomes that we've seen in the past, like SOFA scores. And although they didn't have any reported deviations from their protocol when it came to agent administration, they performed an intention to treat analysis anyways. And they also had really excellent follow-up with 0 patients lost overall. As far as weaknesses go, I wasn't able to actually find or locate the pilot data to support that choice of a 10% difference in mortality in that sample size calculation. A 10% difference does seem particularly large in comparison to other trials that have found a statistically significant difference of 5% to 7%, give or take, between the two agents. The use of the sepsis 3 and SOFA sepsis criteria vary from the use of the SIRS criteria, your systemic inflammation response syndrome, that are often utilized here in the US and may make external validity of this particular trial and application here a little bit more difficult. Additionally, whether or not the patients received adequate fluid resuscitation at that recommended 30 mils per kilo is tricky to interpret, given that the patient's weights were not actually reported. And then I'd also like to point out that they did report 23% of their entire patient population presented with shock prior to intubation, but they didn't actually break that number down and report the number of patients in each group that had shock prior to intubation. So that's kind of up to speculation. Compared to previous studies that have defined or have utilized or evaluated adrenal insufficiency, they didn't define what they were using as adrenal insufficiency, whether or not that was cortisol testing or adrenocorticotropin hormone testing. They didn't explain how they were defining it, which I would have, I think, liked to see. As we noted earlier, although the authors didn't report statistically significant differences between the two groups, I do feel like there were some differences worth noting. We know that lower Glasgow coma scores are a poor prognostic indicator, and a larger portion of the patients in the Etomidate group had GCSs down to 9, while the ketamine group largely had higher GCSs of 14 to 15. And then I think the oxygenation results were also a question that I had, because you can't necessarily identify which group was statistically significantly different. I would have liked to seen that explained a little bit more, with the O2 sats being 100% in both groups, yet somehow still statistically significant. Paralytic or neuromuscular blocking agent was only used in about 70% of patients, and that really seems pretty low in comparison to our practice, at least here in the US. Notably, they didn't use any rocuronium in any of their patients, and so that may make interpretation or application a little bit more difficult depending on the culture and, I guess, preference at your specific center, or paralytic of choice at your specific center. And in addition to that choice of induction agent, the decision to use succinylcholine could have also impacted post-intubation sedation, which wasn't reported out either. And we know that post-intubation sedation can also play into or have an impact on our incidence of hypotension and the need for vasopressors. So ultimately, there were a number of different weaknesses and unexplained gaps in the data that I just presented that I would have liked to have seen in order to or to close those gaps in order to allow this study to actually impact my practice. And so in summary of this trial, in combination with some of the previous literature, the indication for intubation should probably always kind of impact your choice of induction agent, specifically when you're talking about patients that have status epilepticus or trauma. Etomidate and ketamine are not the only options available to us. And so patient-specific factors and clinical scenarios should always be something that you consider. And while adrenal insufficiency, hypotension, vasopressor use may be increased following etomidate, there's really a lot of mixed results on that. And in a majority of the literature, the choice of etomidate or ketamine doesn't actually appear to significantly impact mortality at the end of the day. So this is actually pretty much in line with the Society of Critical Care Medicine's, or SCCM's, new rapid sequence intubation guidelines, which I believe will be released in October next month, that state there's no difference between etomidate and other induction agents in regards to mortality or in regards to incidence of hypotension or vasopressor use, whether that's in the peri-intubation period or throughout the patient's hospital stay. And so I'll be interested to read more about those when those do come out. But ultimately, this trial's not going to impact my current practice. And at that point, I'm happy to answer any questions that the audience might have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.